morning, afternoon, evening, not sure where you're joining us from. We have about 80 people registered for the program from around the world. I'm Holly Preeb from the Cutaneous Lymphoma Foundation, and welcome to our Answers from the Experts Live, converted from our in-person event from Glendale, California to an online version. We ask that you bear with us. Technology is unpredictable right now, and we will absolutely do our best to keep the stream going and answer all of your questions today. The question and answer box should be located at the bottom of your screen. We have disabled chat, but feel free to type in any questions you may have for the doctors in the lower chat button bar. We will do our best to answer all of the questions today. If we don't get to your question, don't fret. We're going to create a secondary list of follow-up responses to circulate to everybody after the meeting has concluded. We do have a couple of polls that we will be putting up. We'd like to get to know who you are and the people who are attending. Additionally, it would, at the end, we'd like to know what you felt, what you learned, and or if you found benefit in this program. We would like to thank all of our individual donors and our corporate partners. Without our donors and without our partners, these programs would not be able to happen. So thank you to all people who support the foundation. I would like to welcome Dr. Pinter-Brown from the University of California, Irvine, and Dr. Jasmine Zain from the City of Hope. Dr. Pinter-Brown is also on our board of directors, and Dr. Zain is also on our medical advisory council. Thank you to you both. Hillary Romke, our program will also be joining us and facilitating all of the questions. We look forward to spending the next hour and a half with you, and thank you for joining us.
Good morning, everybody. My name is Hillary Romke. I am the program manager, as Holly mentioned, and I will be helping to facilitate the questions this morning. So how it's going to work is you can go ahead and, as Holly mentioned, submit your questions into the chat function. It shows Q&A down at the bottom of your screen, and you can just type your question in, and we will get to them as we are able to. So I will go ahead and ask your questions aloud to our docs, and then they will submit an answer. And if you still have another question, you can just feel free to submit as many as you'd like. So I will start out. We have our first question. It's a little bit lengthy, so bear with me. It says, for those with a para-psoriasis diagnosis, not CTCL, can you explain how to self-monitor for progression to CTCL? If the treatment is designed to clear the lesions or plaques, and if early in the disease biopsies rarely show anything identifiable or conclusive, what clues are available for progression of the disease? It then says, the advice that para-psoriasis might one day evolve into CTCL is frankly unnerving, and it's a little mind-boggling that one has to wait until somehow a diagnosis of cancer is possible, although it is unclear how that diagnosis might be made if one is treating the para-psoriasis in the meantime. So I realize this is a little bit different than CTCL, but I'm going to go ahead and direct this to Dr. Zain, if you are able to give a short explanation for us.
Hillary, I couldn't understand anything. The voice was completely broken off.
I'm sorry. Dr. Pinter-Brown, were you able to understand what I was saying?
I think I'm going to paraphrase what I heard. What I heard was, if you're given a diagnosis of para-psoriasis and you're treating it, how would you know when it became mycosis fungoides? Is that true?
Yes.
So as long as I'm talking, I'll continue for a bit, and then Dr. Zain, feel free to add. I would think that the most important thing would be to be observant of your skin lesions, and we tell everybody this. And if they look different, to bring them to the attention of a physician at that time. And then maybe that would prompt a biopsy.
Okay, I'm going to go ahead and start with the next question. I think this may be a popular one considering the circumstances we're dealing with in the world right now. We have a question that says, are we at higher risk for contracting COVID-19 by having MF even if we are at stage 1A?
Who is this question directed to?
Dr. Zain, would you be able to take this one?
And again, I heard only the second part of the question. Hello,
Okay.
Michael, I am having a hard time hearing what Hillary is saying. I hear a little bit when she starts and then it just gets cut off.
Okay, I think we'll have Mike try to address this, and maybe in the meantime, Dr. Pinter-Brown, if you're able to answer if you can hear me, and then once we get Dr. Zain's mic back up and running.
I'll repeat the question as I heard it. The question is, if you have mycosis fungoides, even if you're early stage, are you at higher risk to get COVID-19? I think that the issue is not the risk of getting it, but the risk of having a more severe case. And I think for safety, I would assume that anyone that has had a diagnosis of a lymphoma is at higher risk for having more serious disease and should be particularly careful. And if that's overly careful, then that's fine with me, because we're trying to make sure that people are safe.
Okay, so what I'm going to do is, just since it sounds like people are having a little bit of an issue hearing me, I am also going to type the question into the chat function so that audience members are able to see the question. So if you're having any issues hearing me, I apologize. I will type the question into the chat as well as ask it aloud. So the next question is going to be, my dad has terminal stage 4 T-cell lymphoma. He was diagnosed about 3 months ago and takes 300 milligrams of Bexarotene. Every day he feels worse and worse. Is there anything we can do to slow the decline? And I will direct this, Dr. Zain, are you able to hear me now? It doesn't seem like it. So I'm going to send this over to Dr. Pinter-Brown.
Again, Hillary, I heard the first part that you might.
Okay.
Yeah, so we're going to ask, this is Mike. So Hillary, if you can direct your questions to Dr. Pinter-Brown, and she can answer them first, and then she can repeat the question, and then Dr. Zain, I think, can hear Dr. Brown. So Dr. Pinter-Brown will ask you to repeat the question as you hear it from Hillary. You'll answer it first, and then you'll ask Dr. Zain if she wants to comment, okay?
Okay. Lauren, I'm sorry, Dr. Brown,
Unfortunately, part of the question.
Okay, so what I'm going to do is, Hillary, you go ahead and read the question, and I will repeat it since they can hear me. So as you're reading it, Hillary, I will repeat it. So go ahead and reread the question, please.
Okay. My dad has terminal stage 4.
My dad has terminal stage 4 T-cell lymphoma.
He was diagnosed about 3 months ago.
Diagnosed about 3 months ago.
He takes 300 milligrams of Bexarotene.
He takes 300 milligrams of Bexarotene.
Every day he feels worse. Is there anything we can do to slow the decline?
Worse. Is there anything we can do to slow the decline? Dr. Zain?
Yes, so currently I think we have to figure out what his real diagnosis is, because peripheral T-cell lymphoma is different than skin or cutaneous T-cell lymphoma, and most of the time Bexarotene is used for the cutaneous T-cell lymphoma. So can you tell us where your dad's disease is? What are his manifestations? Is it in the skin? Is it inside his body?
We're going to try to get the answer to that.
We're going to try to get the answer to that. But Dr. Brown, do you have any comments on that?
Bexarotene would not be a good option if this was a lymphoma within his body, inside the body.
Okay. Dr. Brown, do you have comments on that?
I think we could make some general comments to to Dr. Zain's point, saying that someone has T-cell lymphoma isn't so helpful to an oncologist because there's many different kinds. And the prognosis and the treatment is different depending on what kind. Assuming, assuming either a node kind of T-cell lymphoma or a skin kind of T-cell lymphoma, there's lots of other treatments other than Bexarotene. And so whoever is asking the question should be forthright with the physician that their father's feeling worse and what other treatment options are there, because there are other treatment options.
So we do have a message from the original asker of the question. He takes thyroid medicine. It is in his blood.
Okay. The person that asked that first question said he takes thyroid medicine and it is in his blood, Dr. Zain.
Okay, so it sounds like he may have something called Sezary Syndrome if it's in his blood. But again, as Dr. Brown mentioned, there are multiple ways to treat this problem, and I think it's best that they let the treating physician know that his symptoms and what's not working. Now, if on the other hand, if he's not feeling well because of the side effects of Bexarotene, that's again something that they need to discuss with their physician, because Bexarotene can affect your thyroid function and it can make you feel pretty crummy if it's not adjusted properly. So it really depends on what's going on, and they need to really discuss that in detail with their physician.
Okay. All right, here's the next question. I'm going to be reading the questions and Hillary's going to be texting them to me so that everybody can hear. Dr. Brown, what is a punch biopsy and when is it appropriate to get one done?
A punch biopsy is a form of skin biopsy. There's basically two different common forms. One is a punch, so the person doing the biopsy uses an instrument that looks a little like a little miniature, really miniature, cookie cutter to cut out a circular piece of skin that's then sent to a pathologist to look at it. The other type of skin biopsy is called a shave biopsy. And basically, the person doing that shaves a little bit of skin off. And so it looks like, I don't know, I guess pencil shaving would be the best example I can come up with at this moment. So we get any of those skin biopsies, either kind, when we're having a question about what is appearing on someone's skin and we want to understand it better.
Okay. Dr. Zain, anything to add?
I think that's, as Dr. Brown said, they're both useful biopsies. I sometimes try to get the punch biopsy if I'm trying to look at the depth of tumor and we're concerned about folliculotropic type of MF where it can involve hair follicles and deeper tissues. But for most time, either one of those is fine. It's important to get the biopsy to confirm disease progression, transformation, and what's going on inside the tumor.
Okay, and one quick follow-up question from about the Sezary patient. Is it reasonable to be upset that the oncologist won't address this? Dr. Pinter-Brown?
Well, is it reasonable to be upset? I think that oncologists in particular have variable experience in treating T-cell lymphomas. If the person is a general oncologist, it may be that they have not seen so many cases. And in this time, it's a little difficult, but we often urge people to be seen at a center where there's a particular expertise or interest in T-cell lymphomas, at least once, to determine what a good path of treatment would be that then a general or a community oncologist could follow. Now, in this particular time period, many of us are doing consults via video. And so whoever is asking the question may ask if that would be appropriate this time.
Okay. Dr. Zain, any comments?
I totally agree with Dr. Brown. I think sometimes patients in the community are not very familiar with this disease or may not know how to, what the best treatment options are, not because they're incompetent, but just because they don't see this very often. And it's probably better in that situation to request a second opinion or to seek a second opinion on your own. And I think Cutaneous Lymphoma Foundation can be very helpful in that, in referring you to the proper physician, at least for a second opinion, to see what else is out there to help your dad.
Okay, next question, Dr. Pinter-Brown. What's the best way to ensure that a skin biopsy will generate accurate results? I heard that if you're being treated with topical steroids, that it's harder to get an accurate read of the disease in the skin.
That's a great question. So yes, that's true. If someone is either taking steroids orally or is putting them on their skin, it makes it harder for the pathologist to read the biopsy because steroids kill lymphocytes, and lymphocytes are the cells that they're looking for to diagnose a lymphoma. So I would tell people that it would be best if they would refrain from all steroid use for a period of about 4 to 6 weeks before the biopsy is taken. And then we try to biopsy the lesion that's maybe the thickest or the most angry looking so that the pathologist can get the best tissue and try and make a diagnosis.
And Dr. Zain?
I absolutely agree with that. I think that it is important to try to get steroids, either topical or systemic, whatever you're taking, as much as possible. Now, I do realize that sometimes the patient's symptoms are so severe that they get really itchy. It's uncomfortable for them to be off of steroids for very long. But again, every attempt should be made to try to minimize steroid use before the biopsy. Otherwise, the biopsy is not as useful or as informative. It kills off all the cells that we need to look at. So that's something to discuss with your doctor and make sure that you're off steroids before the biopsy is done.
Okay, we're going to direct this next question first to Dr. Zain. How do you know when you've given a treatment sufficient time to work and it's time to switch to another?
Oh, that's a great question. So the short answer is it depends on the treatment. Now remember, skin lymphomas are indolent lymphomas, so they don't grow very fast. And most of the treatments we use for skin lymphoma, whether they're skin-related or systemic, in order to minimize side effects, we choose treatments that may work a little bit slower than a regular chemotherapy that we use for more aggressive lymphomas. So it is important to give sufficient time. And when you're started on a specific treatment by your physician, it is important to discuss with them when to expect a reasonable response. For example, an intravenous treatment used to treat cutaneous lymphomas, Romidepsin, may take up to 2 to 3 months to start showing a significant response. And giving up after 1 or 2 treatments may not be appropriate. And perhaps, a lot of the other treatments used for cutaneous lymphomas have the same, have different times to respond. It's important to know what to expect and to stick with the treatment for that period of time. And I'll ask Dr. Brown to see if she has anything else to add to that.
No, I think that's a great answer. People that are utilizing these treatments for patients know approximately how long it takes to get a response. And so it's so important to discuss that up front with the physician that's prescribing so that your expectations are reasonable. If something takes 6 months, you won't be asking why it hasn't worked in 2 weeks.
Okay.
Exactly. And again, I think the Cutaneous Lymphoma Foundation has some good, has some write-ups about different treatment options, and that's something that you can get, you should be able to get that information from that website as well.
All right. Okay, great. Next question we'll start with Dr. Zain on this one. What are the signs that the disease is progressing?
Can you repeat that again?
Yes. What are the signs that your disease is progressing?
So is this to Dr. Brown or to me?
You can start, Dr. Zain. Dr. Zain.
Okay. So the question is, what are the signs that the disease is progressing? If I'm paraphrasing it correctly.
Yes.
Yes. Okay. So that's an interesting, again, a great question. It depends on where your disease is manifesting. So again, cutaneous lymphoma mostly involves the skin, but you can also have some involvement of the blood. And and sometimes the lymph node. It is actually easier to assess response in lymph nodes and blood because you can measure the blood count and you can see the lymph nodes shrinking. However, skin can be a bit tricky because as the skin heals up, you may see some scaling of the skin, you may see some shedding. There are pigment changes that happens as the skin heals up. And in some treatments, actually, if the patient has tumors, those tumors can start to break down and they start to ulcerate. So things may look a little bit worse before they look better. And again, this is something you need to discuss and be very, your physician should be involved in assessing you very carefully about what's happening in the skin. And you should be able to, and if there's any doubt, I think it's a good idea to have a biopsy done to see if the skin is healing or if the disease is progressing. Dr. Brown, do you have anything else to add to that?
I think another thing that would be important is if you're getting more skin lesions or if they're different in appearance, it would be very important to bring that to your physician's attention.
Okay.
Right.
This next question I'm going to direct to Dr. Brown, Dr. Pinter-Brown first. With the dermatology offices closed, what do you recommend as an alternative treatment if we can no longer receive light treatments?
That's a good question. Well, I guess in the short term, if you live in a place where there's sunshine, I would say get out in the sunshine and expose your skin. Short of that, well, we really don't know how long this will happen. I suppose I would revert back to steroids on the skin, assuming that this is not going to be a very lengthy cessation of light treatment.
Assuming it's not going to be a very lengthy. Okay, go ahead.
Right. And if I may add to that, Mike, I want to say that my dermatologist was telling me yesterday the duration they recommend is 10 to 15 minutes one side of the body, the front, and then 10 to 15 minutes in the sun at the back side, and not to use sunscreen when they do that. That's the only time when you should not use sunscreen when you're trying to treat your disease with sunlight, called heliotherapy.
Okay. Next question. We'll start with Dr. Zain for this next question. I have had mycosis fungoides for over 25 years, stage 1A. However, in the past 5 years, I have progressed from 4% patches to 8% patches. I have never treated the disease since I found out I had it only 5 years ago. In your expert opinion, do you think it's okay not to treat? Will the longevity probably be the same as if I treated it? I'm currently 70 years of age. Also, what other types of cancer could mycosis fungoides turn into or possibly cause?
That's a lengthy question. I'll take the first part. The first part of the question is I've had mycosis fungoides for 25 years, stage 1A, 5%, and then about in the last 5 years, it has extended to about 8%, and it's essentially untreated so far. So my answer to that is that this is still stage 1A, and we know that patients with stage 1A cutaneous lymphoma at time of presentation do very well. Their prognosis is excellent, and in some studies, almost as good as if you never had disease. In particular, since you've never required treatment, it is likely that it may stay that way, or if you do need treatment, it's probably going to be very simple skin-directed treatments that would likely be enough. Given your long history of this indolent disease or indolent presentation in you, it's unlikely that you will progress to a more aggressive form. Based on our experience and data. But of course, cancer, as I always say, cancer can always do something unusual. However, the expectation is that it probably will remain indolent, or you can treat it with something simple like topical treatments or light treatment. The second part of the question is there any association with other cancers? So mycosis fungoides is associated with other types of lymphomas. CLL, or chronic lymphocytic leukemia, has been associated with the mycosis fungoides. It can sometimes be associated with other systemic lymphomas. But in this case, 25-year history, I suspect that it'll probably, you'll probably do very well in the future.
Okay, and can you just, before we ask Dr. Brown to chime in, your audio broke up. Can you just mention again the other types of lymphomas that it is sometimes associated with?
So mycosis fungoides can sometimes be associated with chronic lymphocytic leukemia, CLL, or other types of hematologic lymphomas, even systemic lymphomas and Hodgkin's lymphoma. But again, given a 25-year history, it's unlikely that you will have any problems in the future.
Thank you. Dr. Brown, any thoughts?
When we emphatically state that patients with stage 1A disease do well, that all of those people have been treated, patients don't go to a medical center that has expertise in mycosis fungoides to be watched. So, and I'll reiterate that the treatment wouldn't be very difficult. So, have very many patients, I recommend to them that they receive no treatment.
Okay. All right. We're going on to the next one. Dr. Zain, I was diagnosed with mycosis fungoides 2 months ago after having a biopsy in a lesion in my right arm. After several tests, the doctor said that it is just limited to the skin and I don't have it in my blood. I was referred to a dermatologist for treatment, but with this situation of COVID-19, it is taking too long to get the appointment. So I have no treatment yet, and my lesion is very itchy. Is there anything I can do to relieve the itchiness while I wait to see a dermatologist and get a treatment?
So thank you for that question. I think the question I have is, who did the biopsy? Was this diagnosis made on a specific biopsy? And I assume it was done by a dermatologist. And you could certainly ask them for some treatment advice, whoever did the initial diagnosis. If the dermatologist is not available by visit, I know a lot of our colleagues are doing telehealth type of visits. You could sort of discuss the treatment with them, show them the lesion on camera, etc. In terms of relieving itching, sometimes over-the-counter steroids can be helpful, or try. I think over-the-counter steroids would be the easiest thing to do at the moment to see if that relieves your itching. Given that the extent of lesion is pretty limited, I think you will probably be okay for a few months before starting definitive therapy.
Okay, and I'm just going to repeat part of what you said at the beginning. You mentioned that perhaps the doctor is doing telemedicine visits so that the patient could connect with their doctor by video if they can't get to them in person and/or by phone. But if they can do it by video, perhaps they can show the lesion to the dermatologist by video and get the doctor's opinion on whether steroids or some other interim treatment might be appropriate.
Correct. That is perfect. That's exactly what it is.
Okay, and Dr. Brown, anything you want to add?
No, I think it's a great suggestion. Skin lymphomas lend themselves very well to having video visits. It's not the same as being able to get up close and see it, but you can get a pretty good idea what somebody's skin looks like, and I think that's a great thing to advise.
All right, I'm going to direct the next question to Dr. Brown first. Dr. Brown, do you think that Protopic, I don't know if I pronounced that right, kills T cells in mycosis fungoides? I was recently prescribed this cream, but have not picked up the prescription yet, waiting for your advice.
There's some data about using Protopic on the skin. I have to say in more recent times, the data doesn't look as promising as it did earlier. And there's so many different things to choose from to put on someone's skin that probably would not be my first choice.
Okay. Dr. Zain?
I agree. Even though we have used Protopic sometimes in patients with other types of skin conditions, I personally have not used it for mycosis fungoides or cutaneous lymphomas. There's so many other treatment options that we know work better in this condition. So
All right.
that would be my advice.
Okay, here's one. I have been diagnosed with Sezary. This is for Dr. Zain. I have been diagnosed with
Okay.
Sezary Syndrome stage 4A last August 2019. I have been on the drugs Toctino, interferon alpha, and have had 30 treatments of photophoresis. My condition has not improved or worsened. However, my itch is very bad. I take gabapentin for the itch with little results. My oncologist has just told me that we're going to the next step, which is taking Vorinostat. My question is, will this drug work, and what can I do for this itch?
That's a good question, because itching is definitely a very serious symptom of this disease, particularly in Sezary syndrome. And it's one of the very difficult symptoms to treat because we don't really have good treatments for the itch. My only experience has been that as the Sezary syndrome gets better, as the disease gets better, the itching should get better. So I would certainly address that with your doctor and ask if your Sezary count is going down with the current treatments. Vorinostat has been used. It's a mild treatment, or at least in my opinion, mild treatment for cutaneous lymphomas, but it does seem to have some effect on the itch, and it can be combined with the treatments that you're getting. So it's definitely a treatment to try. But if your Sezary count is going down to 6 months of photophoresis and this combination therapy, perhaps it's time to consider another line of therapy. And there are certainly other treatments out there for Sezary syndrome that may work a little bit better and maybe even faster.
Okay, and just to repeat part of what you said, because it broke up, you said if your Sezary counts have not gone down after 6 months of treatment with photophoresis, it might be time to consider, correct? Another treatment.
Yes, the combination that she's getting,
Okay.
she's not just getting photophoresis, but
Right.
other patient. So what if they haven't been working by now, I consider other treatments.
Okay. Dr. Pinter-Brown?
I couldn't hear what the treatment was before the interferon. It sounded like it started with a T.
Yeah, let me just read that.
I think it was Bexarotene.
Well, no, they wrote Toctino, Toctino. I'm not familiar with that.
I don't know what that is.
Well, I'm not either, and I can't really hear it well. However, I would reiterate, there are some treatments that are more efficacious and more specific to Sezary syndrome. And I would ask the person inquiring to specifically ask their physician what medicines work the best for Sezary syndrome.
Okay. All right. Next question. We'll direct this to Dr. Pinter-Brown. My patches have always been extremely painful and not all that itchy. Is this an unusual response, and should I be concerned?
No, everyone responds differently. Not everybody's patch itches. Some people tell me that their patches burn. Maybe, that's what you mean by painful. And that's just how your body perceives having the lesions.
Okay. Dr. Zain, any comment?
No, I think Lauren is right. Sometimes people have a burning sensation where the patches are a painful sensation, that's just the way their body's reacting to it.
Okay. There was a follow-up question on that Sezary patient. His white blood cell level is within the normal range, but the lymphocyte levels are way below normal. Is that dangerous, Dr. Zain?
Well, having a low lymphocyte count does put you at risk for infections because you're in a state of what's called lymphopenia. But remember, when you have Sezary count, when you do a Sezary count, that also includes the abnormal Sezary cells. When you do a lymphocyte lymphocyte count. You know what the normal lymphocyte count is, because your goal of treatment in Sezary syndrome is to lower the lymphocyte count, which is primarily made up of these abnormal cells. So naturally, when they go down, the total count will go down as well. And that's one of the reasons we consider patients who have Sezary syndrome to have a weakened immune system. So that is certainly puts you at a higher risk for infections, and you have to be particularly careful right now with this COVID-19 infection going around.
And Dr. Brown?
I'm not clear whether the low white count or the normal white count and the low lymphocytes are a function of treatment, or that's the way the person presented. It's unusual for someone with Sezary syndrome to have lymphopenia when they first get diagnosed. So I think I don't have enough information to comment any further.
Because I know sometimes when my mom, who's a Sezary syndrome patient, sometimes her after her treatments, her counts can vary for the first 2 or 3 weeks after a treatment. Is that sometimes the case, Dr. Pinter-Brown?
Yes, and the counts certainly vary over time. And as Dr. Zain said, that's the goal. If you're trying to get rid of Sezary cells, and they are lymphocytes as well, then you'll see fluctuations in the lymphocyte counts, even if the treatment is being successful.
Okay. All right, we're going to direct the next question to Dr. Zain. Let's see here. Why is it that with Sezary syndrome that some treatments work for some patients but not for others? Are there predictive indicators of whether a particular treatment is likely to work with some but not others?
So it depends on the treatment. There are some treatments that work better in the blood compartment. So it involves the blood compartment, and some treatments, for example, which is also vitiligo, or another drug called Campath or alemtuzumab, seem to work better in the blood compartment and the skin. Similarly, ECP or photopheresis seems to work better in patients who have blood involvement. And just the mechanism of action seems to be a little bit more geared towards blood involvement, which is why some treatments will work better with Sezary syndrome versus if you have mostly skin involvement. And we know that about most treatments now, and that's one of the reasons it's based on the patient's disease presentation. So they should be treated more with agents that are likely to affect the blood compartment more than the skin.
Okay, so just to paraphrase, because there was a little bit of breakup, you were saying in the case of Sezary syndrome, and some of the treatments are better geared toward skin, toward treating skin, like and some are better for where there's significant blood involvement. Is that correct?
Correct.
And then why is it that even within patients who have significant blood involvement, certain treatments, whether it's mogamulizumab or photopheresis, do work, but not for others?
That's a great question. It's hard to predict who's going to respond, even with syndrome, to one agent or another. These are some of the questions that are being asked in the research arena. Mechanisms, responses, and I think that research is ongoing. So in the future, we should be able to have better predictors about who would respond to one treatment better, compared to another patient. Unfortunately, that's not in the clinical arena at the moment. I don't know if Dr. Brown has anything to add to that. Predictors of response.
Yeah, I think if we're just talking about Sezary syndrome, we don't really have anything we can use clinically to know which treatment would work the best in an individual patient. But that's true for all treatments. There is no treatment that works 100% of the time. But what we do know is that some treatments are more effective at treating, say, the blood compartment than the skin compartment. And in someone that has Sezary Syndrome, there's blood involvement, so we want to make sure that's adequately treated. So that's in part how we select what treatment to advise a patient, is what area we're trying to target with the treatment.
And like with certain treatments, like let's say Campath, alemtuzumab that Dr. Zain mentioned, are there ways to test for certain cell markers in the blood to see whether the patient might be a responder to that treatment, Dr. Brown?
Well, there's a target against an antigen, something's on the surface of almost all lymphocytes. So while we could check for it, it's not really that important because the target is very broad. Maybe situations in the future where we are able to check for a target, but in truth, in clinical practice, that hasn't been as helpful as one might think.
Okay. Dr. Zain, any comment on that? Oh, sorry, Dr. Brown, go ahead.
Okay, I should explain. Part of the reason for that is just if you see a marker on a cell, it doesn't mean it's not there. It just means that perhaps there's not a huge amount of it. So sometimes drugs may work even when we can't visibly see the target.
Like in the case of brentuximab, someone might have a low expression of certain markers, right, Dr. Zain?
Correct. I was going to allude brentuximab 30. And again, we don't have, we look for CD30 expression to decide who will be treated with brentuximab or not, but the degree of expression we haven't found in the vast majority of cases doesn't seem to correlate with the response, and that may be a function of just the ability to test for that as well. As just we don't, we may not always know if the and how it's being tested and how it's expressed in the tumor.
Dr. Brown, were you going to add something?
No, I was going to use the example of brentuximab. Is a really great example. We know what the target is, it's CD30, but there's so many variables in being able to detect it, including, who looks at it and which biopsy you've done and how many biopsies. And then there are people where we can't see the CD30 on the body response despite that, and that's felt to be because the antigen, the marker on the surface of the cell, is still there, enough to allow the drug to attach to the cell and get into its job, but not everybody can see it with their eye.
And just to paraphrase, because your audio broke up a little there, you're saying, Dr. Brown, in the case of brentuximab, even when there's very little expression under the microscope of markers on the cells that would be a good match, the CD30 doesn't mean it's not going to respond well to that treatment. That's what you're saying, Dr. Brown?
You broke up. I think you said we're going to be pairing our paraphrases, but
Okay.
even though there's a little amount, seen, it doesn't tell you 100% that the drug won't be effective.
Okay. That's great. We're going to move on to the next question. Thank you. Dr. Zain, I have been on decreasing doses of methotrexate for 14 months for mycosis fungoides. I was in the earliest stage when diagnosed, and the skin cleared up within a month after starting methotrexate. I also used steroid creams on the weekends. Now, my monthly blood work shows increased levels, lipase, L-Y-P-A-S-E, and an MRI shows chronic pancreatitis,
Pancreatitis, yes.
Pancreatitis, sorry, which they believe is induced by the methotrexate. I have been taken off the oral methotrexate for a few weeks to see if the lipase returns to normal. How long should I stay off methotrexate, or should I switch to sept cell treatment?
Chronic use of methotrexate is associated with liver toxicity and possibly even liver cirrhosis. I suspect that the elevated lipase and pancreatitis is in the context of liver injury whereas, sometimes I think it's very rare to see pancreatitis alone without liver injury. In any case, I think if it's causing this much, if it's causing a serious organ to be involved, causing toxicity in a serious organ, I think it's time to move on to a different line of therapy. I don't think it's worth the risk to restart methotrexate if indeed that is the reason for this chronic pancreatitis and perhaps liver dysfunction, which may be contributing to this as well, or patch stage or even plaque stage disease that may be safer for you.
Dr. Brown?
Pancreatitis isn't a very common side effect of methotrexate.
Yeah.
However, if people are concerned about it, there are so many other ways to treat early mycosis fungoides. It's not worth the risk to continue something that people have become concerned about.
Yeah. I mean, it's just not worth it. Chronic pancreatitis is a very serious condition. So I'll make sure it doesn't happen again.
All right, next question for Dr. Pinter-Brown. If you don't itch, should you use steroid creams? I understand they thin the skin over time. I was told by an expert a few years ago that steroid creams do not kill T cells. Is that true?
This is such a common question. Actually, steroid kills lymphocytes. That's why we use them. That's why when we're treating systemic lymphomas, we use steroids. It's like chemotherapy to us. But it does thin the skin, and I wouldn't use it unless it's required. I wouldn't just be putting it on for no good reason. But I think there's been a debate about whether it's a cosmetic fix or whether it actually kills cells. But we know very well that steroids kill lymphocytes.
Dr. Zain?
Hello?
Yeah, Dr. Zain, did you want to comment on that?
Yes, I just wanted to comment that it also depends on the strength of the steroids. So sometimes when we use steroids for therapeutic purposes on skin lesions, we use a high potency steroid, usually to try to treat the lymphoma and much less to try to help the itch. So again, the goal should always be to use as little or as dilute a preparation as possible to avoid some of the side effects of thinning of the skin. In addition, if you use it on large parts of the body, steroids will get absorbed and cause systemic effects as well. So they should only be used when indicated and when your doctor advises you to use them.
Okay, next question for Dr. Zain. With patients who have mycosis fungoides, when do you decide to check for blood or lymph node involvement?
So that's a great question. It depends on the stage of presentation. So for stage 1A disease, which is very, less than 10% of body surface area involvement, very minimal disease, the dermatologists usually don't consider doing, any kinds of scan, but they may get you can have blood involvement early on, even in early stage disease. So it's perhaps a good idea to check for blood involvement and get a blood count. And if there's an abnormality, maybe even consider more specialized tests to look for blood involvement. But I would not do any kinds of scans at that point. I would do a physical exam to make sure you don't feel any lymph nodes that are enlarged. And if that's the case, maybe a scan is indicated. I usually get a scan and more definitively check for blood involvement for later stages of disease, at least in the beginning, to kind of see where I am, and at the time of progression, of course. That's my practice, but I'll be curious to see what Dr. Brown thinks about this question.
I check for blood involvement when I meet a patient as a baseline, but I don't recheck it unless it dramatically changes with the disease. I don't order scans very often. Mm-hmm. Mostly, if I felt something on physical exam, and physical exam is really important. If the person had very advanced disease, that is maybe somebody with Sezary's or somebody with tumors, I might get a baseline scan in that instance.
Okay. Next question is for Dr. Pinter-Brown. First, I have a second cancer, even rarer than Sezary, a desmoid tumor. Is it likely secondary to increased incidence of second cancers in CTCL, or could it be due to long-term Bexarotene? I had been diagnosed on it 4 years when, she had been put on Bexarotene for 4 years when diagnosed. Or is it due to short-term Romidepsin, which made the Sezary worse and was time-wise related to the appearance of desmoid? Sezary got worse after major skin toxicity from attempted treatment of desmoid with sorafenib. Is chemo, and they put in parentheses doxil, my only alternative so that treatment for one cancer doesn't exacerbate the other? Please speak to the use of chemo.
Well, I'm a lymphoma specialist, so I'm not going to speak to the treatment of a desmoid tumor. But what I can speak to is that Bexarotene isn't a carcinogen. Desmoid tumors aren't associated with cutaneous T-cell lymphoma. Certainly, if you got a skin rash from another drug like sorafenib, your skin lymphoma would look worse for a variety of reasons. It might be very, very helpful if the doctors treating the two separate conditions, or if there is one doctor, if there is one treatment that would treat both, that would be ideal. I'm not sure that that's going to be the case. But these are really different kinds of problems that really shouldn't have much to do with each other, nor should the treatments.
Dr. Zain?
Yes, I don't have anything else to add. I mean, I do have a patient who actually has desmoid as well, but that was in an area where it could be excised and they did not need systemic therapy to treat their cutaneous lymphoma. But I don't know of any treatment that would cover both those diseases. And I agree with Dr. Brown that, there's no association that I know of between those two conditions.
Okay, moving on to the next one. Dr. Brown, is this disease genetic, CTCL?
It's a great question, and we could generalize it to all lymphomas. So lymphomas are generally not felt to be diseases that are commonly genetically transmitted. However, there are reports of families that appear to have more than their share of very small amounts of patients with lymphomas, probably less than 10%. And we don't even know why those families have too many lymphomas. As an example, there's not a marker, there's not a chromosome abnormality like you might find in breast cancer or colon cancer or some other cancer that would identify who in the family is at risk, or even why the family has been found to have members with lymphoma. So at this point, it's just an observation that there are a few families that seem to have a share of lymphoma in the family, and that's really all we know.
Dr. Zain?
I agree. I don't know. There are clusters of families or family members who may have different types of lymphomas within the same family, and it may have to do with some genetic abnormality that's not consistent across different families. But it may also have environmental influences because people in the same family get exposed to the same environment. And maybe one of the reasons we see a higher incidence of certain types of blood cancers or within a specific family member. But in general, these are not considered inherited disorders, and you cannot give them to your children or, I always tell patients that because they worry that they're going to give it to another family member. It's not contagious or inherited in that way, at least as far as we know.
All right, next question for Dr. Zain. Even if mycosis fungoides is stage 1 and just limited to skin at the moment, is there still risk that I develop Sezary syndrome or another blood cancer in the future? And how often should I have blood tests done, such as complete blood count and flow cytometry?
So the risk is small. If you have stage 1A mycosis fungoides, generally the prognosis is excellent. However, in terms of, so the first part is can you develop Sezary syndrome? So that is this can happen, but generally we find that patients with Sezary syndrome usually present with more advanced stage disease. So I would suggest that unless you have symptoms, unless you do need follow-up with your doctor, you don't need to have blood work done on a regular basis. There's nothing that's going to either predict, whether you're going to develop Sezary syndrome unless you have symptoms. So, I would just suggest that you have a careful clinical follow-up with your physician, or treating physician, at least once or twice a year, and have a good relationship with them so you can discuss if you feel that some things are getting worse. So, and again, as Dr. Pinter-Brown mentioned, we always do a blood test in the beginning when we first see our patient to establish whether their blood involvement is there or not. And beyond that, I don't think you need to unless you actually have worsening symptoms. As far as other cancers are concerned, so there is a relationship of mycosis fungoides with perhaps other types of lymphomas. And again, there is no good way to screen for them other than if you start to develop symptoms, in which case you will need to seek medical attention. There's no, there's no regular testing that we can do to predict if this is going to happen to you or not.
Okay, and again, just to repeat, you said there is the potential for other types of lymphomas, but there's no way to predict that.
Correct, and it's a very small incidence, so just careful follow-up and attention to your symptoms.
And Dr. Brown?
Two things, I guess. One thing that might interest the audience is that there's a body of work suggesting that Sezary syndrome is actually a different disease, even though, we have this staging system and we treat mycosis fungoides and Sezary syndrome like they're a continuum, like they're different ends of the same thing. In fact, it may be true that Sezary syndrome comes from a slightly different cell. And that is why, as Dr. Zain said, when patients come in with Sezary syndrome, that's usually the first time they're seeing a physician. It's not that they had early-stage disease and ignored it or something like that, and then it became Sezary syndrome. That's just how they come to a physician's attention. In terms of other cancers, there is no way to screen for lymphomas, but there has been some epidemiologic data looking at other cancers like colon cancer, as an example, that has a slightly higher incidence of mycosis fungoides patients. And I would just ask everyone to adhere to the screening recommendations that exist for all of us with respect to routine screening colonoscopies, because these screening tests, are well advertised, and all we have to do is adhere to the advice of the different bodies of physicians that make these recommendations.
Okay, great. We continue to get great questions from the audience. Moving along here, when this will be for Dr. Brown first. When my absolute clone size was 120 cells, my doctor said some normal people have low counts like that. Is that so? Also, other than no residual disease, what is an absolute clone size that suggests adequate control of blood disease? And the same doctor told me that some people itch more even when they're getting better. Is that true?
Boy. So starting with the first question about clone size, I'm not sure what that even means. Are we talking about absolute numbers of normal cells on flow cytometry? I don't know what clone size means. So is it possible for somebody to be walking around with a clone T cells and not have a disease? Yeah, that is true. Some people have a clone of B or T lymphocytes, and there are names for that. And basically the important part of the name is unknown significance. So we don't know what that means when somebody has a clone and it's not creating a condition. And we tend to see the development of clones in an asymptomatic person as our age goes up. I remember the question about itching, that itching gets worse as you get better, not usually, unless it's from something. And then there was a question in between that I don't remember.
All right, wait a minute.
Maybe about minimal residual disease.
What did you say? Itching is usually a sign of when you're getting worse, not better. Is that what you said?
Well, I don't know about worse, not better, but itching generally correlates with the response in the skin. some drugs, as Dr. Zain mentioned, are particularly good at treating itching, but if we look at it in general, as someone's skin improves, usually their itching improves. The exception to that would be someone doing phototherapy. Sometimes phototherapy just causes itching. I think maybe because the skin gets dry, but in general, the symptoms track the improvement of the disease.
Okay. And then the other part of the question, I think you addressed, but it's other than no residual disease, what is an absolute clone size that suggests adequate control of blood disease?
I don't know what the answer to that is, but in point of fact, I would be depending much more on the person's skin than the amount of cells in the blood, because my very first goal is to make sure that someone's comfortable. And so my very first goal would be that their skin is improving. And then secondarily, I would be interested in what the blood looks like. And I'm not sure there's a number that I would pick that represents good or bad control for a particular patient.
Dr. Zain?
So again, I'm not sure what the clone size means, but I could address another aspect of this question. I think the goal that we are working towards in this field is to get a clone of disease, which is not, was called minimal residual disease or a molecular remission. Because when we, for example, in patients we try to cure with a stem cell transplant, we want to make sure that their clone is not detectable by any means possible. And certainly there's data out of Stanford showing that if you can achieve a status where the clone is not detectable even by molecular methods, that those patients do very well. So that is our goal. We're not, a lot of our therapies don't get us there. But as Dr. Brown mentioned, the first goal is to try to palliate the symptoms and get the skin cleared off. The blood involvement is not that important unless the patient has Sezary Syndrome. That's the second goal. So that's my answer to this question.
Okay. Thank you for that. Next question, we'll start with Dr. Zain. Is it common with CTCL stage 1A to have consistent low body temperature? For example, 35.3 to 35.7, I presume that means Celsius.
That's a great question. I actually don't know the answer to that. I do know that with mycosis fungoides, there is, because it involves the skin, there is body temperature dysfunction, mostly because the skin, and I assume that would be more in patients who have more extensive disease. So with stage 1A, I'm not sure there's enough skin involvement to actually, affect our temperatures. On the other hand, there's also some interesting data that I just read that our body temperatures are actually going down. We are, in general, our average temperatures are a little bit less than what was, the 37 degree. But I don't have a good explanation for why your temperature is low at this point. And then maybe you can have your thyroid tested. One other explanation could be that if you're on a Bexarotene type of treatment, maybe that's causing some thyroid dysfunction that can result in lower temperatures, but I don't know if you would be treated with stage 1A disease with that.
Okay, and your audio got broken up a little in there. I'm just gonna, did you say that it could be because of the thyroid function that the temperature could be low?
Yeah, so in general, low temperatures are associated with low thyroid function. And that could be a separate problem, or if the patient is on Bexarotene, their thyroid function to be affected, and that could potentially lead to a lower body temperature.
Okay, thank you. And Dr. Brown?
I couldn't hear, so I hope I'm not being repetitive, but any thyroid low function can contribute to low temperature from whatever cause. And then when you were talking about temperature dysregulation from skin diseases, I just want to, if it wasn't made clear, that doesn't manifest in a different temperature that you would take from your body. It manifests as the person's inability to feel comfortable in different temperatures. For example, someone where it's very, 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 very hot outside and they're freezing and they're wearing 4 layers of or people who have a lot of skin disease that are in air-conditioned buildings and they're just extremely uncomfortable in that environment. Their skin is not performing its function as our thermostat. However, if we were to measure their temperatures, they would be relatively normal. It's just that their body is incapable of regulating the temperature well enough where the person would feel comfortable.
Okay, thank you. Next question, and again, we appreciate everybody being patient with us. The technology, the internet is, so many people are using the internet, and the systems are somewhat overloaded, but we're all doing our best to make sure everybody's questions are answered. For Dr. Pinter-Brown, with COVID-19, doctors may need to make ethical decisions on who gets advanced interventions and respirators. Having cancer is one of the considerations. Would CTCL stage 1A be a factor, or at what stage?
I think these are very, very individual decisions. I would hope that the decision, if someone had any cancer, would be made in concert with the oncologist to advise the intensivist of what the person's prognosis is. There's no rules if that's what people believe, that if you have cancer, you're not going to get the care that you need.
Okay, Dr. Zain?
I agree. I mean, it's very hard to generalize an answer to this kind of question. And this is really a discussion that you have to have with your oncologist and the intensivist.
All right. Next question for Dr. Zain. Are patients with mycosis fungoides with small patches considered immunocompromised and at greater risk if they test positive for COVID-19? If so, what makes them immune compromised? Should they take greater precautions than the general public?
That's a great question. So we do know that mycosis fungoides, even in early stages, is associated with a slightly weakened immune system. How much, it's very difficult to quantitate. We don't have those kinds of measurements, even though they may have normal blood counts and so on. So yes, they are at increased risk of complications of COVID-19. The data, as you know, is still evolving. We're not, people are just getting the experience now about how different types of cancer patients are reacting to this infection. But in general, we know that the complication rate is higher if you are at a higher risk of, if your immune system is not as strong as a normal person. So certainly you need to take all the precautions that are being suggested by CDC and your health authorities, including social distancing, hand washing, and so on, staying away from people as much as possible, and be extra careful knowing that you're at higher risk of complications as well as acquiring the infection perhaps. You can certainly minimize your visits to doctor telemedicine. Please use that tool as much as possible. Avoiding hospitals is a good idea. As we get more and more cases, they are going to be more dangerous places for you than for normal people. That's what I have to say.
Okay, so just to paraphrase, you're saying obviously follow all the guidelines that are being communicated, and then to take some extra steps of precaution and use telemedicine when possible with your doctor so that you don't have to be out going into doctor's offices or certainly the hospital where there's greater risk for infection. So take all precautions possible because even at early stage disease of CTCL, there is somewhat the immune system is somewhat compromised, so you should be as careful as possible. Is that right, Dr. Zain?
Absolutely, absolutely.
And Dr. Brown?
I would totally. In addition, mycosis fungoides tends to be in older people, and that would be another reason for someone to be particularly cool. But I think we should all be very careful about where we go and how we deport ourselves.
Okay. All right, great. Next question. Dr. Brown, is cutaneous lymphoma curable?
There's lots of cutaneous lymphomas. So are we talking about cutaneous T-cell lymphoma, like mycosis fungoides? I'll answer that question, since that's the more common. At the present time, the only mode that we have to cure it is with an allogeneic transplant. That means you're getting a new immune system from someone else by means of their stem cells. Then people would say, well, I want that. That's very simple. I want to be fixed, but it's not a simple thing, and it has a lot of potential complications. And so we rarely employ that for a patient, although it is sometimes done. But we know that in the patients that have had allogeneic transplants, because it was appropriate in their situation, that many of them never have recurrence of their disease.
Dr. Zain?
Yes, I agree. At the moment, we consider an allogeneic stem cell transplant to really be the only potentially curative therapy, but it does come at a huge cost of chronic immunosuppression and complications of the transplant. So the risk of those complications has to be weighed against the possible benefit of cure, which obviously everybody wants, but we don't want to we don't want to give that treatment to patients who have early stage disease, because some of the complications of transplant could be pretty severe. Having said that, even I always tell patients that nothing is 100%. Even an allogeneic transplant is not 100% cure. There are patients who may even relapse after an allogeneic transplant. So we have to be very careful in choosing that form of therapy for patients.
Okay. Dr. Zain, we'll give you the next question. When in the disease stage is a good time for a patient to consider a clinical trial?
That's a great question. So I think we should, when you, at any stage of your disease, you should always ask your physician about a clinical trial. And the reason being that even though we have a lot of treatments, as I mentioned, none of those treatments are curable. They don't cure patients, and we are always doing new research to try to find new ways of treating these diseases. So it's a good idea to ask about a clinical trial. Obviously, you don't have to be treated on a trial if there's a standard therapy that works better for you, but that discussion should always be part of your treatment plan. That's my suggestion to patients.
Okay. And Dr. Brown?
I would agree. It's part of the discussion of options, but people have to realize when there's a clinical trial that we don't know that the drug works. So many people will ask me, what are the results of the clinical trial? But we don't know the results until it's over. So it's so important to consider them, because without clinical trials, we wouldn't have all the options that we currently have. But realize that clinical trials are performed because there is a scientific question. And the scientific question might well be, does this drug work for somebody? Is it a helpful thing? Should we have it as an addition to the drugs we now have?
All right. Let's see here. Next question. We'll send this one to Dr. Brown. I was diagnosed with mycosis fungoides 21 years ago, stage 1A, progressing to 1B. I have mostly done phototherapy and have a national biological at-home unit. In surgery, I've had trouble getting the surgical site healed, so I'm staying away from the light therapy. However, I'm concerned about some raised red marks appearing on my skin, treated with cholesterol, proportionate ointment treatment, 0.05%. My in-person appointment is not until June 22nd. Should I make an earlier appointment? Should I make an earlier appointment? Yes, I think that's the question.
I'm so sorry. All I heard was someone that had mycosis fungoides for 20 plus years, and maybe they have a home light box and they're worried about some new marks. Did I get most of it?
Let me just read a little bit again. I'll repeat it. So they've 21 years, stage 1A, progressing to 1B. They've mostly done phototherapy, and they have a national biological at-home unit. In December, they had melanoma on their skin, or on their shin, I guess, and had Mohs surgery. They've had trouble getting the surgical site healed, so they're staying away from light therapy. However, Let's see here. I'm concerned about some raised red marks appearing on my skin, treated with clobestol, proportionate ointment, 0.05%, and their in-person appointment is not until June 22nd. Should they make an earlier appointment?
Okay, so sure. If you're concerned, maybe your physician has the ability to do telemedicine. I shouldn't suggest this for other physicians, but patients often send me pictures before we had telemedicine and they couldn't come in. So there's ways of communicating your concerns to physicians. I would applaud your cessation of the light therapy when you have a melanoma. Many physicians would be concerned about using phototherapy, even if it's narrowband UVB in the setting of a prior history of melanoma.
Okay, and I think we have time for, I think it's one more question here. So I'm just going to pull that up. And we're going to start with Dr. Zain on this one. So let me direct this to Dr. Zain. I have mycosis actually, we'll have two more questions. So here's one. I have mycosis fungoides now for 28 years. I was just diagnosed with Notalgia Paresthetica. The NP drives me absolutely crazy with itch, but my patches do not itch. Are these two conditions related?
Can you tell me what the condition was? You cut off there.
Yes.
So mycosis fungoides
for 28 years and was just diagnosed with Notalgia Paresthetica. So that's Notalgia.
Again, you cut off after no.
Notalgia Paresthetica. Notalgia Paresthetica.
Okay.
And the NP.
Notalgia Paresthetica?
Yes. And that drives the person absolutely crazy with itch, but their patches do not itch. Are the two conditions related?
So to be honest, I don't know what this condition is. Dr. Brown, are you? I'm looking it up as I go. I don't know.
It's like a sensory neuropathy where
like
you
a neuropathy?
I would say they're not related.
Okay. Yeah. Okay. So this is some kind of a neuropathy then.
Okay.
So I would say it's not related.
Okay. And then we've got one more question. We'll start with Dr. Pinter-Brown, and that is CTCL and bug bites. Do CTCL patients have to be more careful with insect bites? I found out the hard way my reactions to bug bites are so harsh because of the CTCL. Which protection is best? That's an MF1A patient writing that question.
There actually isn't an association between bug bites and a bad reaction. The association in hematologic malignancies with chronic lymphocytic leukemia. I have never seen a report of mycosis fungoides, but that doesn't mean this individual doesn't have bad reactions to bug bites. As to what the best way of not getting bitten by bugs, that's a difficult question because many of the very strong repellents, if you had bad skin disease, might be very uncomfortable. I think that would be a question I would direct to the dermatologist who has seen you so that they could make a better determination of how much skin involvement you have and which product that's effective against bug bites would not irritate your skin.
And Dr. Zain?
Yes, I agree. I think there's no connection between bug bites and CTCL or severity of bug bites. In terms of what to do, I mean, I think just speak to your dermatologist about the best bug repellent, but also just, when you go out, have a full sleeve shirt and try to expose less of your skin to bugs, which is what I do because I get really sensitive to the bites as much as possible.
Okay. Well, go ahead.
One other statement. I just want to say there's a condition that looks like bug bites that is associated with mycosis fungoides. It's called lymphomatoid papulosis. And sometimes they look really ugly. So I would make sure that you truly had a bug bite that turned sour and not a lymphomatoid papulosis lesion.
All right. Well, that's great. I'm going to
Right.
turn this
I
meeting.
agree.
I'm going to turn this meeting back over to Holly Preby, who is going to wrap us up. Holly.
Wanted to make sure that I said thank you to all of you. We recognize there may have been some technical challenges through this call, but the fact that you stuck with us and you brought your questions and you trusted us to help today, it really means a lot to us, and we are here for you. I also want to thank both Dr. Pinter-Brown and Dr. Pinter-Brown, did you have any last final thoughts before we conclude for today?
No, thank everybody for hanging us and stay safe.
And how about you, Dr. Zain?
Hello? Yes?
How about you, Dr. Zain? Did you have any final thoughts that you'd like to share?
I just wanted to say thank you very much. I think we had a great question and answer session. In spite of all the technical challenges, and please everybody stay safe, stay indoors, follow all the guidelines recommended.
Wonderful. Thank you so much, both of you, for joining us today. And again, for the audience, thank you again to our donors and our corporate partners for making this program possible. And if you would please, as an audience member, take a few seconds to provide us some feedback so that we can help to improve these programs going forward. As you know, our in-person programs are being shifted online, and we know that we're going to have some challenges when it comes to technology, but we want to bring you the best experience possible. Please take care of yourself, stay safe, reach out if we can help you. We are here for you anytime, please. Phone, email, through our web. Thank you so much for joining us today, and I look forward to receiving the results. And again, thank you so much, Dr. Pinter-Brown and Dr. Zain, for your time this morning, for joining us. Have a good day. Bye-bye.
Thank you. Okay, bye-bye.
Bye.
Bye.
Bye.